Good afternoon, everyone, and thank you very much indeed to ΕΛΛΟΚ for having me here. Thank you to the moderator of the panel and to all the fellow panelists here. The session and the whole conference is named after, a sort of implementation approach and strategic approach that we want to take from theory to practice. And it is exactly the purpose of the work that Allcan International has been carrying out now for a number of years across the world, and it has become a true community of practice in over 24 countries, from Australia to Mexico, Canada, and several European countries, among which Greece stands out as being one of the most dynamic and one of the most successful in the steps and in the progress that it has achieved. From theory to practice implies that I will not dwell too much on the theoretical part of the story. And in particular, I would just like to set out a sort of background against which we will comment, we will also discuss very specific topics, many of which have been touched upon in the very rich discussions this morning. So you will hear concepts, objectives, issues that will not be new to you. However, my main point is that we need to have a strategic framework which applies to everyone and which allows the entire cancer community, whether at the national level, European, or even international level, to identify objectives, goals, and implement those targets in a coherent manner. Now, you are very familiar also, by way of introduction, with the European policy framework, Europe's Beating Cancer Plan. The action guide of Allcan is conceptually, again, strategically part of that concept, but it's very specific and it is somewhat different from it. So let's try to align, first of all, how can I say, on a wavelength which focuses on what is called efficiency in cancer care. Efficiency is not a theoretical term. Efficiency is not a word which has been invented by myself, Allcan, or anyone within our network. Efficiency is a concept which has been already developed and advanced by international organizations from the OECD to the WHO, and it has become, again, one of the parameters of reference also for legislators, policymakers across Europe. The other important element which I would like to bring to your consideration is that, as the WHO representative mentioned this morning, what gets measured gets done. Therefore, having metrics for the entire care pathway, which allow to learn from our experience, from our successes and weaknesses, allows the entire system to improve. The performance of care will improve. And the metrics can only be implemented in a system if the data is available. So bear in mind again that a sort of precondition to talk about performance assessment, monitoring and evaluation of a care system is to have data available across the pathway. The work which has been done in the course of the past couple of years and which was then implemented or published through this action guide was done in collaboration with the Medical Center of the University of Amsterdam, a well-known group of researchers that collaborates with the OECD, with the WHO, and with the European Commission as well. And at the risk of oversimplifying the process, we came up with a starting point that includes 8 core metrics, 8 core metrics that define efficiency, particularly from the onset of the care pathway, from diagnosis to treatment, or what's the primary care interval. All these steps can be measured and therefore can be considered as an element of strength of a care system or a gap. The 8 core metrics were then clustered into 3 major areas, thematic areas. Again, these are concepts which will not sound new to you, but I insist on the fact that it is important to structure them in a systematic manner in order to have a clear and agreed strategy ahead of us. The 3 clusters include timeliness of care, coordination of care, and person or people-centeredness. They sound broad, they have to be broad, but within each of these categories, the metrics are not infinite, but certainly they can be increased and can be fine-tuned as the whole care system improves. So just to give you a sense of what I mean by that, the 8 core metrics in reality have become 130 metrics within the 3 clusters. And the 130 metrics are being tested, piloted, in a couple of countries in Europe. One is the NHS in England, another one is a couple of hospitals in Germany. So the concept again of what gets measured, gets done, and allows for improvement implies that the same medal, the 2 faces of the medal, are jointly addressed. The main face of the medal is what matters to the person, what matters to the patient. The other face of the medal is how the healthcare system can be efficient, sustainable, and therefore can deliver the best possible outcomes, can deliver the value that is required, and moreover can deliver quality, both quality of care, which translates into quality of life for the patients affected. So in extreme synthesis, you see here this diagram, which in reality is the compendium of a lengthy set of thoughts and analysis. I will briefly take you through the recommendations which have emerged, the key recommendations which have emerged in the 3 clusters that I mentioned. Under timeliness of care, I draw your attention to the importance of creating a health data ecosystem. And that's, again, at this point, a sort of broad definition, but it has to be spelled out very much along the lines of several comments and several interventions in the morning. It has to be spelled out with electronic health records, cancer registries, etc., genomic profiling, and harnessing the value of these data represents an acceleration in person-centered cancer care. At the same time, we're talking about standardizing care pathways. Standardizing care pathways is a very, very complex work, which to some extent goes beyond, in fact, to a large extent, goes beyond the clinical guidelines which we normally refer to. It is more of a systemic approach which includes other stakeholders in cancer care. And that's why I move to the next cluster, which is coordination of care, where you will see that there are two maybe categories that emerge, or two definitions that emerge as being critical in a person-centered care pathway. One is the role of the nurses. The nurses, even if one can be jealous about the absence or the existence of nurses, there was a nice comment this morning on this point, they are essential. And our work in understanding the value and the role of nurses is to advocate and to advance these type of strategic objectives towards the achievement of a clear role and a clear presence, physical presence, as much as needed of nurses. The same applies to care navigators. Sometimes they are considered synonyms. The nurse becomes the care navigator. It's not always the case. It also depends on the system, how it is structured. Examples are emerging from countries like Australia, where they have legislated cancer care navigators. And the navigators are both healthcare professionals or psychologists, in other words, with a slightly different background, however, with a job description which targets exactly what we have in mind here. The other important elements that stands out from these recommendations is the multidisciplinarity of the work. Again, a concept that has been addressed today and which I underscore once again: coordination of care with the help of a navigator at the presence of a nurse, with the availability of data, allows a much more efficient and effective outcomes-driven care pathway. The third and final bucket is about patient-centeredness. And here again, the emphasis which has emerged from the research is about the co-design role that patients and all other people who are affected, even in the family, can have in co-designing the care pathway. One specific point, which again would not sound particularly new, is the need to include patient-reported data, patient-generated data, whether it's PROs or patient-reported experience, as an integral part and measurable part of the care pathway. All of these implies and leads to the conclusion that empowerment of people affected by cancer, their caregivers, is a fundamental element of this strategic framework. So, in closing, and in extreme synthesis, we do not need to go through all the details, but there are elements which have been, across country, validated as being fundamental pillars in a national cancer plan. Evidence-based strategies imply, as I was saying at the beginning, that data is available and therefore an ecosystem, an infrastructure, as well as the appropriate processes are put in place in order to harness the value of such data and create a learning system. Monitoring and evaluation is in particular an area which has been dear to the heart of the OECD for a number of years already. And in this context, the fact of measuring the performance of systems, care systems, has become really a priority in many countries. Now, this is not without conflicts, and this is not without some sort of controversy, to the extent that measuring performance and measuring interventions and policies, etc., obviously may imply a change of state of play. So those who are interested in changing and moving from status quo are certainly more available and more active, proactive in implementing such measures. Those that defend a status quo, which is not necessarily in the best interests of patients, and it's not delivering outcomes as we mean them, tend to avoid even the debate. So let's keep that in mind. It is something which requires courage to advance. Lastly, stakeholder involvement. Stakeholder involvement leads to person-centered care pathways. And person-centered cancer care pathways are almost the summary of everything we have said and we are trying to implement these days. This is perhaps not the newest frontier, but it is certainly one of the strategic and policy goals that the entire cancer community intends to achieve now. Tailor to the needs of each individual the care which will deliver the best quality, the best value, and the best outcomes. Thank you.